$471 was the last. ఈ రెండు
Good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaz. एग्जाम आएगा एग्जाम जाएगा धर्म क्षेत्रे कुरुक्षेत्रे. So every year, similar day before exam comes, the day of the exam comes, the day after the exam comes. Anxiety of the people is similar. Some students will be praying, why not postponement? By postponing a pregnancy, you won't get a natural abortion. You should learn how to carry pregnancy. You should be prepared for pregnancy, right? So good to see Mohit Kumar, love indeed, रोडगे विदा. सर एग्जाम के पहले दर्शन दिए आपने, अब एग्जाम बढ़िया हो जाएगा. बढ़िया, that is called faith. Faith in teacher, faith in Almighty. We need to have faith, right? And most important, we need to have faith in ourselves. And that will come when you have logically prepared for the exam. So thank you all guys who have joined today. I also came to cheer you up mainly, so that good to see Pramod Gurjar also. Most important thing to the exam is not the knowledge. Tomorrow when you go to the exam hall, the most important factor that you need to carry is your trust in yourself. 5 years medical school you studied. You have seen cases, you have prepared nights together for your MBBS exams. Actually, entrance is supposed to be of the basic standard of MBBS exams. So that is the reason, carry the common sense, carry the trust, carry that you are being created by the Almighty to become something in life to save the patients. Whether you get 100th rank, 1000th rank, 2000th rank, if you are destined to become a MD general medicine, naseeb mein likhe to wahi banoge. So please think that God created you to become that great. Already you are great because you cracked one level in MBBS. Right? So with that preamble, let us revise today our favorite subject, general medicine. So last time we discussed third heart sound. Where do we listen? Ventricular dysfunction. Always one very important rule, remember. What is happening in mitral stenosis? Left atrium, left ventricle. Already stenosis is there. When 500 ml blood has to go into left ventricle, only 300 ml only is able to negotiate. Already left ventricle don't have any work. If it doesn't have any work, why will it fail? It won't. So always the rule of the game, remember. If it is a pure mitral stenosis without any regurgitation, two things you will never find. They are against diagnosis of a pure mitral stenosis. A normal heart shadow, there is no cardiac enlargement. If there is any cardiac enlargement, it is never pure mitral stenosis. Because already amount of blood coming into the left ventricle itself is lesser than normal. Why will heart enlarge? No. So normal heart shadow is the rule. Dilated heart shadow is against the rule. And S3, which is the heart sound of a failed heart, is never a feature of the pure mitral stenosis. That is what you need to remember. So if you listen S3, Or if you listen, if you see a dilated cardiac shadow, what does it mean? Either MS is accompanied by mitral regurgitation or aortic regurgitation, or the uh, the heart has some other reason to fail. That's the only thing that you need to remember. So why in MR or AR the left ventricle will fail? Because if the MS is accompanied by MR, then what will happen? Only 300 is coming. 300 only is coming. But when left ventricle is trying to pump the blood forward into the aorta, out of the 300, 200 is going back. So the forward flow decreased. When the forward flow decreased, the aortic valve closes early and the ventricular systole is over faster. So the heart rate will increase. And when the heart rate increase, demand in the periphery is driving the heart to beat more frequently. The heart one time will fail. Right? So because of this forward, unable to eject the blood into the aorta. So that is the reason, unless MS is accompanied by MR or MS is accompanied by AR, pure MS will never lead to S3. Pure MS will never lead to the dilatation of the heart, is what you have to remember. Point number 472. Let us master. So, doctor, fourth heart sound, where will you listen it? So you should know that fourth heart sound, fourth heart sound is loudest at the left ventricular apex. Make the patient to go into left lateral position, and then don't use diaphragm, because fourth heart sound, third heart sound are all high amplitude, low frequency rumbling sounds. So put your bell, not the diaphragm, left lateral position at the left ventricular apex, right? Then you listen the fourth heart sound. Fourth heart sound is more felt to your fingers than you listen, because it's a high amplitude sound. So what leads to worsening, accentuation of the fourth heart sound? So first of all, why fourth heart sound occurred, we discussed earlier. Whenever left ventricle is getting filled from the left atrium, first 1/3, why does it happen? The moment mitral valve open, left atrium is full pregnant with blood, left ventricle has undergone isovolumic relaxation. The pressure inside it is decreased. Agree? So, first 1/3 occur because of the pressure difference. Second 1/3 of the left ventricle filling occur because left atrium is at higher level than the left ventricle and gravitational pull. Last 1/3, atrium actually contracts and pushes the blood into left ventricle. But if this left ventricle is hypertrophied, it is not elastic, then left atrium has to use a lot of pressure to push the blood into left ventricle. And that makes you to listen the fourth heart sound, is what you need to remember. So suppose if the person is doing, let us say, isotonic or isometric exercise in supine position, lying down position. When you do the isometric exercise, what will happen? Catecholamines increase. And the increased catecholamines will increase the pressure in the aorta, because catecholamines will lead to vasoconstriction. So total peripheral resistance, what will happen? It will increase. So whenever the total peripheral resistance is increased, high pressure in aorta will cause high pressure in ventricle. And Into this, the left atrium has to push. Already ventricle is hypertrophy. Then left atrium need to use more pressure. If the arterial load is more, if the pressure in LV is more, and already ventricle is non-elastic, then atrium in the last 1/3 of ventricular diastole need to use more pressure. That's the reason fourth heart sound is accentuated with isometric or a mild isotonic exercise in the supine position is what you need to remember. So, what do you need for S4 to be produced? Let us say left ventricle is hypertrophy. Atrium should contract forcefully to push the blood, no, for the S4 to be produced. Suppose if the atrial fibrillation is there, then there is no chance of listening S4, even if left ventricle is hypertrophy. So S4 is absent with atrial fibrillation. S4 is accentuated with the isometric exercise. S4 is produced because of the forced atrial contraction into a non-elastic ventricle, which is hypertrophied, typically seen in the hypertensive individuals who are having ventricular hypertrophy, is what you need to basically remember. Similarly, if there is a ventricular aneurysm, what will happen to the ventricle? Ventricle becomes more compliant. Unlike hypertrophied ventricle, which is less compliant, whereas aneurysmal ventricle is more compliant. That is the reason S4 is characteristically absent if there is a ventricular aneurysm, is what you need to remember. So, what is the common reason for ventricular aneurysm? Whenever there is any myocardial infarction, one of the post-MI complications is that ischemic necrotic infarcted wall become weaker, and that lead to development of ventricular aneurysm. But in a ventricular aneurysm guy, if you are able to hear S4, then it is against the diagnosis of ventricular aneurysm. So where is S4? Absent. S4 absent in two situations. One is ventricular aneurysm, other is atrial fibrillation. S4 is increased with lying down in supine position and isometric exercise. And S4 is typically heard in the left lateral position. And it is better heard with the bell rather than diaphragm. So these are 4 or 5 points you need to basically remember. Now comes the ejection click. So good to see Ganesh Reddy. Today only I heard a very good news. Ganesh Reddy has found a room in Hyderabad. He is going to come to Nampalli. Wow. So Ganesh Reddy, 1+1 offer. While coming, you bring one of your friend, we will give a free coaching to him. Right? Ganesh Reddy is already our paid student. So you bring your girlfriend, Ganesh Reddy's girlfriend will get a free coaching, right? So, but don't charge any other classmate and bring her, showing that she's my girlfriend, right? There should be a proof that she is your girlfriend. Then we will give a free coaching to both of you. So, from Monday onwards, Girija Reddy, Sai Reddy, Ganesh Reddy, this becomes a Reddy platform. They will all be attending every day evening. I'm really excited and very happy to know that. Because for teachers like us, it is the students, whether online or offline, you attended means we are very happy for that wonderful evening. Right, doctor? Ejection click. So totally there are 1200 points in cardiology. If you do revision with me these 1200 points, even DM cardiology entrance you can crack. I can guarantee you that. So ejection click is a sharp, high-pitched sound, means low amplitude sound. Low amplitude means we use diaphragm, not the bell. And when do you hear ejection click? Immediately after the first heart sound. So why will you listen first heart sound? Because the mitral valve, tricuspid valve closes, you listen first heart sound. Immediately after the first heart sound means what is ventricle doing? Contracting. So ventricle is in systole. So when ventricle is in systole, what is happening? It is contracting. Initially isovolumic contraction, rise the pressure, open the valve. When you open the valve, the semilunar valves, aortic and pulmonic valve, suppose if the valve is stenotic, or if there is a very high pressure in the root of aorta, then the valve need to open. It is stenotic. There's a pressure building underneath it because ventricle is contracting. So what will it do to the stenotic valve? It will cause the valve to bulge before opening. Because there's a lot of pressure under it, it's a stenotic valve. Or there's a very high pressure above the valve, as in hypertension. So it will it will be bulging. And that bulging makes you to listen the musical sound called ejection click is what you need to remember. So ejection click happens after S1. It happens in early systole. It happens because of the pressure building during the systole underneath the stenotic valve, causing the bulging of the stenotic valve, leading to the musical sound. So, what is importance of ejection click? First of all, where do you listen ejection click? Whenever there is aortic valve stenosis, pulmonic valve stenosis, or if there is a hypertension, in all these scenarios, you listen ejection click. So what is the importance of click? If you look at the aortic stenosis, you remember very well that aortic stenosis, if you take, a obstruction can occur below the level of the aorta. In HOCM, what is happening? Anteromitral leaflet and interventricular septum are coming close to each other, and left ventricular outflow tract got obstructed, narrowed down. So that is a subvalvular obstruction. There can be valvular obstruction and there can be supravalvular obstruction whenever the supravalvular aorta is stenotic. In conditions like Williams syndrome, right? So there is a supravalvular aortic stenosis. So where do you listen the ejection click? You don't listen it if the obstruction is subvalvular. You don't listen it if it is supravalvular. You will only listen it if it is valvular, is what you have to emphatically remember. So now, let us talk a bit about the clicks. There is one click that is heard in mitral valve prolapse. Mitral valve prolapse. So why will that click happen in mitral valve prolapse? When the left ventricle is contracting, if there is a mitral valve prolapse, that prolapse will be because the pressure in the left ventricle, the mitral valve, which is a prolapsed valve, will prolapse at that time. That makes the chordae tendineae, which are holding the mitral valve, chordae tendineae are holding the mitral valve. They will make that cooing sound, which is the click. So, but mitral valve prolapse click is more of late systole and mid systole. Whereas ejection click of aortic stenosis and pulmonic stenosis is more of early systole. That is one differentiator. Then one more thing. Whenever any maneuver increase the venous return and increase the volume of left ventricle, increase the left ventricular volume. So what conditions will increase the left ventricular volume? Isometric hand grip exercise or squatting. In all these situations, left ventricular volume become increased, either due to venous return or increased LV volume during isometric hand grip exercise, or when you are squatting, what is happening? When you are standing, there is a decreased venous return. When you are squatting, more venous return. Once more venous return means more atrial blood coming into ventricle, and ventricle become enlarged. Then when the left ventricle volume is higher, then the chance of the prolapse are lesser, right? Hence click become delayed. It moves away from S1. Sometimes it will even disappear, and the mitral valve prolapse associated mitral regurgitation murmur become lesser, shortened. That is what you need to remember. Once more summarize, doctor. In mitral valve prolapse, if the left ventricle size is smaller, the prolapse is higher. So anything that increases the venous return or increases the LV volume size, as in hand grip exercise or in squatting, where there is a more venous return to the heart and ventricular size is higher, then the prolapse is lesser. Obviously, you will start rubbing your classmate's shoulder if it is a crowded classroom. If it is a large ventricle size, there is a chance of some students prolapsing into the other room. Right? Just like in bus. In the bus, if it's a big bus, 5 passengers only, nobody will be hanging. If it's a small bus, 5 passengers also need to hang. It's prolapse. Right? So, prolapse is lesser whenever there's increased venous return or anything that increases the left ventricular volume size, and that will delay the MVP click. It moves the click away from the S1, and the click may disappear, murmur is shortened, is what you need to remember. Any maneuver that decreases the venous return, decrease the LV volume. Similarly, if you are standing position, decrease venous return. Then Valsalva maneuver also. What is Valsalva maneuver? Expiration against a closed glottis. Whenever you are doing a forced inspiration, there is a negative intrathoracic pressure which will suck the blood from the great vessels into the heart with inspiration. Negative intrathoracic pressure. Whereas expiration is opposite. Positive intrathoracic pressure that will impede the blood from entering into heart. So less amount of venous return will cause smaller ventricular size and more prolapse. So any maneuver that decreases the venous return, decrease the LV volume, or standing position with decreased venous return, or Valsalva maneuver with expiration against a closed glottis that create positive intrathoracic pressure, which will prevent the venous return to the heart. Anything that decreases venous return to the heart, anything that decreases the LV volume size will make the click to occur early, regurgitation to start early, murmur to get prolonged. That is what you need to remember. So tomorrow, NEETPG exam. MVP murmur. What is the effect of Valsalva, standing, squatting? If it doesn't come, मेरा नाम मुरली भरद्वाज नहीं है. Paper out. You will say, think, wow. This was the question yesterday we were discussing. One question definitely will come from heart sounds, S1, S2, S3, S4. One question will come from hypokalemia, hyperkalemia, ECG. Hypocalcemia, hypercalcemia. Right? Standard, doctor. Every time you go to Ooty, Shimla, or any hill station, there will be sunrise point, sunset point, suicide point, eco point. Same points. Only your girlfriend is different. Right? So, entrance also is very, very, very standard. Mohit is asking, sir, this offer is also for our girlfriend. Okay, if girlfriend joins the class, will boyfriend get a free coaching? Oh yeah, definitely. Definitely. Yeah. And we are also very much liberal with the LGBT. If at all any issue is there, no worries. You can bring your same-sex roommate also. We will give, even if you don't have relation also, we will give a free companionship offer, 1+1. First you come to class, we are happy. Right, doctor? Good. So, yesterday, one student, Arvind, I met in the airport. He is a interventional cardiologist working with the Indraprastha Hospital. So I was just getting in. So he came and uh, made a pranam. So I said, I don't know. Sir, I'm Dr. Arvind. Then 5 years I attended only watching your YouTube videos without paying single rupee. So I did none of the commercial coaching centers where I paid money did not help. Attending your YouTube video every day, bindas, we used to enjoy. And Xerox Center fellow used to give the Sunday question papers. So I said, I'm happy. Interventional cardiologist is like whole world. So many lives are there in your hand. But such a great cardiologist, once upon a time learned what is S1, S2, S3, S4. I had a privilege to be a teacher, means there is nothing more required on the planet Earth, right? So that's the point, doctor. Throughout your life, only two things happen in a doctor's life: teaching and learning. Teaching and learning. Our patients are the best teachers. They tell the story of their life. Suppose you have given diuretic, doctor. After taking diuretic, patient will come to you and tell, doctor, because of your diuretic, my hypertension, edema, everything relieved. Or because of your diuretic, I have to go so often to the urine. Because of your diuretic, I got hypokalemia and cramps. Ultimately, textbook will only teach you what, give a diuretic to a hypertensive. But after taking the diuretic, what is the experience? Who will teach you? Patient will teach you. And every day by talking to the patients, we become more and more experts. So we should thank Harrison or we should thank patient? We should thank patient. That's the reason, even if you don't read Harrison, if you are treating patients, you are still knowledgeable. Right? So that's the reason only two things happen in our life. Either we teach or we learn. We teach or we learn. So I remember putting an endotracheal tube in emergency, at least to 200 to 300 nurses. But one day I tried, very short neck, unable to negotiate ET tube. Every time it is going into esophagus. Suddenly the second year nursing student to whom I taught, 1 minute, will you give me a chance? There used to be Mini is her name from Kerala sister. 1 minute, will you give a chance? Yeah, please take. Then, all right, doctor, stuck, tuck, tuck, tuck. Within one shot, she went into trachea. Right? So, but she learned how to put endotracheal tube just about 10 days before that. I love to do intubation. After that, every time an opportunity comes, I used to ask Mini to put. So in the 10 days, she got at least 5-6 patients practice. Ultimately, when I'm unable to negotiate, she is able to negotiate and put it. So that's the reason. To your team, as you keep teaching about, I wrote this prescription, what is the reason I wrote this prescription, why I started this antibiotic, what is the importance of this. Once you are teaching to your nursing team also, what happens, doctor? Your knowledge improve, they become knowledgeable. Ultimately it is beneficial to the patient, right? So that's the reason learning and teaching, they are the only two things in our life. Systolic thrill in left second and third intercostal space. So we already discussed left second and third is pulmonic area, right second and third is aortic area, right? So though the aorta is on left side, it goes towards, sorry, this is not left, this is right, this is left. So the aorta goes towards here. So aortic valve is resting in right second and third intercostal space. So pulmonic stenosis will lead to the ejection click, and also it lead to a systolic thrill. Thrill is nothing but a palpable murmur is the thrill. So in the left second and third intercostal space is what you need to basically remember. So where do you see pulmonic stenosis? Commonly TOF, tetralogy of Fallot. Always remember, tetralogy of Fallot has got 4 lesions. What are they? Overriding aorta, opening mouth into right ventricle, left ventricle, both of them. Then pulmonic stenosis, then right ventricular hypertrophy, then ventricular septal defect. Common Viva question examiner will ask you is, what are you listening, Raju? Sir, I am listening a systolic murmur. Because already somebody told you diagnosis TOF. Oh, why are you listening systolic murmur, Raju? By mistake, if you say it is because of the VSD, mar gaya. Always the VSD that you see in tetralogy of Fallot is a very significant sized VSD that it does not lead to such a sonorous murmur, systolic murmur. Though VSDs are known to lead to systolic murmur, but the systolic murmur that you listen in the top is not due to VSD, but because of pulmonic stenosis. Remember, right? Second question commonly asked. There is a VSD, there is a overriding aorta, there is a right ventricular hypertrophy, there is a pulmonic stenosis out of all these lesions. Which decides prognosis of your patient. How severe is the pulmonic stenosis decides the prognosis of the patient. It is not the VSD, it is not the overriding aorta, but it is the PS that decides the prognosis of tetralogy of Fallot is what you need to emphatically remember. If you look at the cyanotic TOF, it is only a mild degree of pulmonic stenosis. So all cases of the TOF are not cyanotic. When will they become cyanotic? But generally, is it the right to left shunt or left to right shunt that lead to left to right, left blood mixing to right, or right blood mixing to left? Which will give you cyanosis? Oh, no. Left is good. Good kisses the bad. Nothing happens to bad. But bad kisses the good. That is the whole thing, na, funda. ASD, VSD, PDA. In all this, what is happening? ASD. Left atrium to, this is right atrium. Left atrial pressures are higher than right atrium. So shunt happens from left to right. Left to right is good, means cyanotic. VSD, left ventricle to right ventricle, but left to right. So good. PDA means it connects the aorta and pulmonary artery. Once more, aortic pressures are higher than pulmonary artery. So even that is also left to right. Pulmonary artery is right. Aorta is left. So ASD, VSD, PDA per se are what? Cyanotic. When will they become cyanotic? So when the left to right shunting is happening, more blood is coming into right side. More blood is going into pulmonary artery. A time will come where pulmonary artery will develop pulmonary artery hypertension, and that high pressure of the pulmonary artery reflects in high pressure in right ventricle, right atrium. So when right atrial pressures are higher than left atrium, then the shunt will reverse. That time the ASD becomes cyanotic. BSD becomes cyanotic. PDA becomes after the development of pulmonary artery hypertension. And why pulmonary artery hypertension develops? Because all these cyanotic ASD, BSD and PDA bring more blood from left to right side, more blood into the pulmonary, into the aorta. So that increases the aortic pressure. Pulmonary arterial, more blood into pulmonary artery. That increases the pulmonary arterial pressure. Agreed? So TOF also. What is the problem in TOF? There is a overriding aorta looking into both the pulmonary artery, both into the right ventricle and also into left ventricle. So when the blood enters from right atrium into right ventricle, the right ventricle blood has three choices. What are they? Either it can go into pulmonary artery, or it can go into aorta, because aorta is overriding aorta. It is opening the mouth into both right ventricle and left ventricle. Third option, through VSD, it can move into left ventricle. Right? So, suppose if the pulmonic stenosis is very mild, what is preferred path for the right ventricular blood? Directly into pulmonary artery. But if the pulmonic stenosis is severe, so what is the option for the right ventricular blood? Instead of into pulmonary artery, it will enter into overriding aorta. And that will cause the mixing of right ventricular blood with left ventricular blood, which is also going into aorta. And that lead to development of cyanosis. Understand, doctor? Right? So, pink TOF means a cyanotic TOF. Whenever there is a mild degree of pulmonic stenosis. Usually such a mild degree of pulmonic stenosis is not associated with the development of cyanosis, is what you need to remember. And the systolic thrill that you listen in the left upper parasternal zone in the patient of TOF is because of not VSD. It is because of pulmonic stenosis will lead to systolic thrill in the left upper parasternal region in the pulmonic area. You listen because of the pulmonic stenosis, not because of the VSD. Though VSD is capable of causing the systolic murmur, the VSD that you see in the TOF is the one which cannot cause such a loud murmur. Now comes Epstein's anomaly. Let us talk about it. Oh, it is 8:30, doctor. Very good, very good, very good. My main purpose is to meet you and tell you, Dhairye Sahase Lakshmi. Right? अच्छा खाओ पियो, एग्जाम को जाओ, जितना आंसर करो करो. Don't worry about our score predictors, mock test results, time you wasted in life. All these things. Becoming medical student itself is a big waste of life. Beautiful life. In our obituary column, they will at most write DR. So, DR. That means jiska zindagi barbaad hua. Otherwise, who is the person at the age of 28, 29 will still study doctor? Except we useless doctors, right? So that's the reason. Enjoy, use common sense, carry it, and that is only save you in the exam hall. And once more, we will all meet. We will have a discussion together of the question paper. What questions aaya? Wahi questions hote hain. What are the questions that came? Everything we will have a discussion. Right, doctor? Thank you so much.